morning, everyone. Welcome to the second episode of the University of Michigan Sound Support's Parent Webinar Summer Series. My name is Emma Brooks, and I am the Sound Support Coordinator for the University of Michigan's Hearing Rehabilitation Center. I hope you all are having a great summer. As many of you are aware, Sound Support is an outreach grant funded by the University of Michigan Department of Otolaryngology and Michigan Medicaid. The grant is designed to provide outreach and support to children with hearing loss throughout Michigan. We've put together this series of webinars for parents due to the great responses from last year's series. We hope you'll find them to be helpful, and we encourage you to share topic ideas for future discussions with us on our evaluation, which will be sent at the conclusion of our three-part series. We strongly encourage your feedback and suggestions. You will find presentation slides located on the Handouts tab located on the toolbar. You're able to download these or print them directly from your computer or device. There is also a Questions tab. Please feel free to ask questions throughout the presentation, and we will address them at the end of the talk. If you are watching a recorded version of this webinar, please email any questions to me at oto-soundsupport@med.umich.edu. Today's webinar is titled Auditory Verbal Therapy, the Who's, What's, and Why's. I would like to take the opportunity to introduce our presenters today, Abriz Farhad and Ellen Thomas. Abriz is a bilingual speech-language pathologist at the University of Michigan Cochlear Implant program. She received her bachelor's in linguistics and communication disorders from Michigan State University. She earned her Master's of Science in Speech-Language Pathology at the University of North Carolina at Chapel Hill and completed specialized training at the UNC Children's Cochlear Implant Center. Since then, Abriz has worked in several clinical and research settings in the field of pediatric hearing loss. Prior to joining the University of Michigan, Abriz worked at the Auditory Verbal Center in Atlanta, Georgia, and held a faculty position on the Cochlear Implant team at the University of Southern California in Los Angeles, California. Abriz provides intervention for children with hearing loss in Spanish, German, and English, and is currently pursuing her certification as a listening and spoken language specialist, certified auditory verbal therapist. Ellen is a senior speech-language pathologist and LSLS certified auditory verbal therapist at the University of Michigan, where she provides direct intervention to children with hearing loss using an auditory verbal approach. I'm going to go ahead and hand it over, and we will get things started. Good morning, everyone, and thank you so much for tuning into our webinar today. And thank you, Emma, for those introductions. As Emma mentioned, we're here today to discuss auditory verbal therapy, the who's, the what's, and the why's. My name is Abriz Farhad, and I'm one of our speech-language pathologists here at the Hearing Rehabilitation Center and Cochlear Implant Program. And as Emma mentioned, I'm joined today by my colleague, Ellen Thomas, who is a fellow SLP with our center and a certified auditory verbal therapist. I'd just like to take a moment to provide an overview of our Cochlear Implant program. We are very fortunate here to have an interdisciplinary team where we work closely with our surgeons, our audiologists, and our speech-language pathologists to support our patients with hearing loss across the lifespan. Many of you may already be familiar with Emma at this point. Emma Brooks is our sound support coordinator, and she helps us to provide outreach educationally and in the community to our patients with hearing loss. Ellen and I would also like to take a moment to acknowledge the reason that we're able to present to you today, and that is due to our sound support program. So what is sound support? It is a grant that was established via the Michigan Medicaid Matching Grant in 2004. It's funded by a 50-50 cost share program between the Department of Otolaryngology and Michigan Medicaid. And really the goal of this program is to improve the quality, timeliness, and effectiveness of treatment received by deaf and hard of hearing children in the state of Michigan. So to that end, we're able to provide education, training, and collaboration to parents and professionals regarding earlier intervention, auditory therapy, and optimal use of hearing technology. And included within that mission is our ability to provide this webinar today. Just to provide you with a quick overview of what we're going to discuss today, we're going to go over the who's. So, who is a good candidate for auditory verbal therapy? We're also going to talk about who provides auditory verbal therapy, which professionals do this, and how might these professionals be different from those that you have encountered thus far in your child's hearing loss journey. We will discuss what is auditory verbal therapy and how this intervention is different from traditional speech and language therapy. We're going to talk about what it takes to be successful in this approach. We're going to discuss why a family might choose an auditory verbal outcome for their child, and if they do choose this approach, why it is so crucial to start early in the child's life. Finally, we're going to leave some time for questions and answers, and we'd also like to share a few resources with you all where you can go in your own time to gather a little bit more information, not only about auditory verbal therapy, but about early intervention and language development. All right, so let's begin. Who is a good candidate for auditory verbal therapy? The short answer is most young children with hearing loss will be candidates for this approach. However, this approach aligns well with families whose goal is a listening and spoken language outcome for their child, achieved with the aid of their child's hearing technology. You may be familiar at this point with the communication options that exist for a child with hearing loss. We have some listed over in the green bar on the left, and you may also be familiar with some terms that fall under this listening and spoken language umbrella. You may have heard terms such as auditory verbal therapy, auditory oral education, auditory deaf education, and oral deaf education. While these may all sound similar, they are different, and we're going to talk specifically about auditory verbal today. However, this umbrella of listening and spoken language is committed to teaching children with hearing loss to listen and talk. Now, regardless of whichever outcome you choose for your child or whichever approach you use to communication, what is vital is that it is the family's informed decision, a choice that they are making for their child. At its core, the auditory verbal approach is an early intervention approach. The goal is to teach a child with hearing loss to listen and speak. It is not intended to be remedial. Therefore, ideally, it has to be implemented in this critical, fleeting period of brain development from birth to age 3.5. Now, you're probably thinking, wait a breeze, are you telling me that I have only 3.5 years to set the foundation for my child's future if I want them to listen and talk? And the answer is yes. While that might seem like a blink of an eye, we know from cognitive research that 85% of a child's brain is formed by age 3.5. That means this is an important time when connections are being made. And for these children, this is the time to lay those auditory pathways, those foundations in the brain. Having said that, children up to the age of 6 or 7 may be candidates for this approach. This may particularly be true if the child has had a progressive hearing loss, maybe their hearing has dropped over time, or they've had a later onset hearing loss that we see with things such as cytomegalovirus, CMV infection. You may have heard that when you had your child. But overall, we do know the younger the child, the better the prognosis or our anticipated outcome for that child to be a successful listener and spoken language communicator. However, over time, we do know from research and our own experiences as listening and spoken language providers that outcomes can be dependent on a variety of factors, some which we can control for and some which we cannot always control for. The ones that we encounter most frequently are going to be the age of identification of the child's hearing loss. We will say this again and again and again, early is better, followed by how early was that child's hearing loss aided, and if traditional amplification, like hearing aids, did not work, how soon did they undergo cochlear implantation? In addition, device use is crucial. So we define full-time device use as at least 10 to 12 hours a day. Ideally, a child should be wearing their optimally fitted state-of-the-art hearing technology, whether that's hearing aids, cochlear implants, a bone conduction device, all waking hours when they're not sleeping at night, when it's not nap time, when they're not in the bath. The device should be on the child's head and functioning. I always tell my kids, I don't take my ears off during the day and put them in a box. So your hearing technology needs to be on your head 24/7. And another thing that we will stress again and again is that we do not truly hear with our ears. Rather, we hear with our brain. Therefore, having ears that function or optimally fitted hearing technology is providing access to that brain. This approach is developing the brain. Parents and caregivers. So whoever is the most involved in the child's life and is rearing that child, as with any thing in life when it comes to child rearing, the parent plays the key role. So parents who attend therapy, who are keeping devices on their children, who are taking what they are learning with their child in auditory verbal therapy every week, and creating a lifestyle where that is part of the child's daily routine, that is what's going to make the difference. That is what makes a child a successful listener and speaker. It is not the 1 hour a week that you spend in the therapy room, but rather what you do with that knowledge. In addition, daily exposure to an enriched auditory learning environment. What do we mean by that? So we know from this foundational study by Hart and Risley, which was reiterated in this 30 million words book by Dr. Dana Susskind, which was a bestseller just a couple years ago, that the achievement gap starts early. And this is not just for children with hearing loss. We know that by age 3, children from higher resourced families on average hear 30 million words more, 30 million spoken words more than their peers from lower resource families. And of course, many of these factors we've already discussed come into play in this. Perhaps parents who have to work more outside the home or longer hours simply are not able to spend as much time socially interacting with their children. But if we think about the auditory brain like a savings account, every word a child hears is like a dollar bill being deposited into that account. The goal is that by age 3 and then beyond, these children have the largest possible savings account in their auditory brain. And we know that those children who have bigger savings accounts by age 3 go on to be the children with better language outcomes, higher rates of literacy, better academic success, and later professional success. So it starts early. Of course, there are also factors we cannot always control for. For example, the anatomy of the ear. Some children may be born or develop inner ear anatomy or auditory nerve anatomy, which connects the inner ear to the brain. That may not be typical. These children may still receive benefit from amplification or cochlear implants. We just can't always predict if it will be equivalent to a child for whom the anatomy is considered normal. Children may also have additional diagnoses or developmental delays that may affect their language learning potential or their progress. Having said that, that doesn't mean they can't benefit from auditory verbal therapy. And if this approach does not work for your particular child, there may be one of these factors we can control at play, but it's also important to know that it doesn't mean that the child has failed in this approach, but rather perhaps this approach, something needs to be tweaked in order to better meet that child's needs. Okay. Now that we've talked about who is a good candidate, let's talk about who can provide auditory verbal therapy. The short answer again is that this is a listening and spoken language specialist. So what does that mean? An LSLS is either a speech language pathologist, there in the blue, an audiologist, as you see in the green, or a teacher of the deaf, as you see in the yellow there, who is not only qualified in their profession and appropriately licensed and or certified, but this person has elected to undergo an additional 3 to 5 years of rigorous, specialized, intensive training under the mentorship of a certified listening and spoken language specialist. Following this, the professional sits for a rigorous exam, after which hopefully they will be able to obtain the certification of listening and spoken language specialist. This certification is managed globally by the Alexander Graham Bell Academy. There are two possible designations within this approach. Our team has auditory verbal therapists. So an auditory verbal therapist works in a one-on-one sort of interaction, one therapist to one family in an individual session. It is also possible to be an auditory verbal educator. The key is that the auditory verbal educator also includes the family in their intervention. However, they may serve the child in an individual, group, or classroom setting. Finally, this certification provides families with assurance. You are assured that you are working with a professional who is highly trained and specialized and understands what it takes to teach a child with hearing loss to successfully listen and talk. Over here on the right, we have a resource that we encourage you to check out on your own time when you have the chance. It's really wonderful. It's from the Hearing First organization's website, and it talks about how to find quality listening and spoken language programs in your area. More than that, there is a really beautiful PDF that I point parents to, particularly if they're going to be moving out of the region where we can provide them services. And it talks about what to look for in your listening and spoken language provider. So perhaps prior to even establishing that relationship with a professional, it gives you ideas of what to think about, how to quantify your own goals for yourself and your child, and what kinds of questions to ask. And then once you've entered into that professional relationship, it gives you some more things to think about, questions to ask, and sort of a little bit of a checklist to follow. Of course, there will always be personal differences, but this approach is one which you will be in for it's a lifetime, but you will be working with your professional typically at least 2 years on average. So you want to work with someone that you feel that you can trust and who is giving you the type of feedback that you need. As I mentioned, we have auditory verbal therapists here at the University of Michigan. We're very fortunate to have 4 SLPs who are able to provide auditory verbal therapy. So here we are pictured from left to right. There's me on the left, Abriz Farhad. That's my colleague, Jennifer Still, Kelly Starr. And then there on the right is Ellen Thomas, who's going to be taking over here in just a few moments. Okay, so to review, we've talked about who could benefit from auditory verbal therapy, who provides the specialized intervention. Now we're going to move into what is auditory verbal therapy? What makes this approach unique? So auditory verbal therapy is a specialized intervention that focuses on developing the auditory pathways in the brain, there's that keyword again, in the brain, needed for speech, language, cognition, and literacy. We are accessing the brain through listening first. Once more, we're going to say it again and again. We do not hear with our ears or even our hearing technology. We truthfully hear and listen and make connections with the brain. So auditory verbal therapy takes advantage of developmental synchrony. Developmental synchrony means that the goal is to help the child with hearing loss to take advantage of the natural stages of neurologic, cognitive, and language development by assisting that child in acquiring communication outcomes and milestones at approximately the same rate and around the same age as a typically hearing child of that age would. Okay, what we know from research into the brain is that brains are programmed to acquire certain skills at certain times. There is a reason that you crawl before you walk, right? So developmentally appropriate learning is going to be much easier on that brain and much more natural than remedial learning. That is trying to learn a skill outside of that developmental window that it is intended to be acquired in. With auditory verbal therapy, we're always going to want to follow developmental milestones. So we're not doing anything outside of what the brain would typically do if it had been born a hearing brain. Now, for auditory verbal therapy to truly be called that, it must be grounded in 10 guiding principles. Ellen is going to go over those guiding principles a little later in this talk. Also, it should always include one family working with one therapist. We have a one-on-one individual relationship. Auditory verbal therapy does not follow a set curriculum. There is no A, B, and C. Rather, it's always diagnostic in nature. That means that we are continuously evaluating and monitoring a child and their progress and using that to determine where we're going to go next with that child. But it should still be following a developmentally appropriate trajectory. And we're also going to try and push that child to progress as fast as the child is able. To that effect, we also encourage education with same-aged hearing peers in a mainstream classroom setting. The reason is that ideally, the goal for outcomes for a child with hearing loss in this approach is for them to successfully communicate by listening and talking at an age-appropriate level that's going to be commensurate with their same-age peers who do not have hearing loss. So for that to happen, you need to be surrounded by peers who listen and talk appropriately. And more than that, who have age-appropriate social skills, social language skills, and cognitive skills. And what we think about when we're putting a child in mainstream education is that we're trying to set that bar high. A child can only grow as high as the bar is set. So it needs to be set at age appropriate. If it's set any lower, then the child cannot achieve beyond where the bar is. All right. So auditory verbal therapy, again, it's one therapist to one family. And what is vital in this approach is that the parent is the primary and most important language teacher. The listening and spoken language therapist is not the most important teacher. We are the coaches. We are there to help guide you in what to work on, how to work on it, when to work on it, and when it's time to move on to the next level. So if you take any sport as an example, I like to use soccer because that's my sport. We like to think of it as the parent and the child are the players on the field. The listening and spoken language specialist is the coach on the sidelines who is guiding and providing feedback. We're also here to provide support because we know things don't always go according to plan and we need help steering. And we all have those days where things are tougher than expected. So when those days come up, we're here to provide strategies, techniques, ideas tailored to your child to help sort of problem solve and get it back on track. All right, so this is going to be the last thing that I talk about, and then I'm going to turn things over to Ellen. And one of the questions I get most often from parents when we're just starting out is, what is auditory verbal therapy going to look like for my child? Now, even though auditory verbal therapy does not follow a set curriculum, it does, however, have some recognizable stages. And we're going to talk a little bit about what those stages are. It is often a play-based therapy. It shouldn't feel to the child like they're doing work. It should be functional. It should be something that can be carried over to the child's daily routines, their daily life, and what they do day to day in school. So early on with our infants and toddlers, we're very often at the learning to listen level. At this level, we are helping the child learn with hearing loss, who is using their hearing technology to learn to create meaning associations between sound, okay, and objects or actions. So that association of sound with meaning. This is the level where we often play with those learning to listen sounds that may be familiar to some of you. So, for example, I'll talk a little bit about what we're doing in therapy this week. We're doing the 3 Little Bears. So with this level, we might be working with the 3 Little Bears on the bear says grr. We might be telling the story of Goldilocks, and uh-oh is used to alert the child to something has happened. So maybe the chair broke or the porridge was hot. We might be doing yummy when she's eating the porridge, or shh, night night, to sort of help the child understand that that means somebody is sleeping. The next level, I like to call language experiences. The child has learned to listen, has some functional language, and from here on, we can really delve into an experience with the child. We can incorporate in that experience all of the child's auditory, speech, and language goals. So with the Three Little Bears, we might be telling the story with props, incorporating songs, which we do at every level, maybe have a nonfiction flip book about bears, maybe we're doing a craft, all to tie in the child's goals and work on this one experience. Those of you who have been in therapy with me with your children might recognize the bottom picture there. This spring and last spring, we planted tiny seeds, and over time we took pictures of our seeds, and hopefully, if we were lucky, they sprouted and grew, and children would bring in their pictures of their sunflower or their beans for us, and we'd make a language experience book so the child could narrate back to us what they had done. This next level sort of melds into language experiences, but takes it to sort of a more multi-layered level, and that's thematic units, where we might delve into a theme over several weeks with the child. At this point, their language is pretty sophisticated. So what we might do, for example, with the Three Little Bears is that we're doing Fairy Tales and Fables month. So perhaps week 1, we're doing the Three Little Bears. Week 2, we'll do another fairy tale that has the 3 in the title. So maybe the Three Little Pigs. And by week 3, we're doing the Three Billy Goats Gruff. And this child is able to, has this rich vocabulary and is able to compare and contrast. Maybe we're working on some early literacy, some early reading and writing, maybe writing a story ourselves. And by this point, the child is becoming very sophisticated. And the next level, ideally, is they should be graduated from therapy. At this point, the child is ready to be, if they're not already, transitioned to a mainstream classroom setting, either preschool, kindergarten, or hopefully no later than first grade. All right, so we've provided a little overview of what therapy looks like. I'm going to turn things over to my colleague Ellen, who's going to share with you a video of one of her early listeners who is still in this learning to listen level.
Thanks, Sabrice. Now we're going to watch a short clip of a therapy session that, as she said, is early in the process of learning to listen. At the time of the video, this child was 19 months old and had been listening for 6 months. And he has a unilateral cochlear implant. At the time that this child was implanted, bilateral cochlear implants were not readily an option. So I'm going to take you through this video.
The washer. Put it in the washer. Put it in. Put it in the washer. The water in there. Put it in the washer. Good.
This one too.
Put it in the washer.
Okay. Put it in. Yeah, hot bud.
Put it in the washer. This one. Little soap. Shake it in. Shake, shake, shake. Yay! Wishy-washy, wishy-washy, wash, wash, wash.
Wishy-washy, wishy-washy, wash, wash, wash.
Wash, wash, wash. Wishy-washy, wishy-washy, wash, wash, wash. Let's see, did they get wet? Oh, look, it's wet. Wet. That one's wet.
So I hope that one of the things you notice when you're watching this video is that we've got a 19-month-old who's willingly sitting up at a table and is engaged and is listening. He's not talking, which is fine at this stage. He's taking it in. We also have a parent that's engaged, and we have an activity that will carry over into home because everybody does laundry. So we've got some language that the parent is going to be able to continue to use during an activity that occurs in day-to-day life. The wishy-washy refrain uses a sing-song voice with a strong rhythm, and it's going to help this early listener grab onto that language, learn it, and retain it. Auditory verbal therapy sessions always revolve around several different areas within the same session. At its core, we're looking at audition, and that's the ability to use hearing in order to be aware of your environment, to understand the language that's being spoken to you, and to retain it. So we're ultimately looking for a system that can understand a school direction that might be open your science book to page 45 and answer questions 1 through 3. We're also looking at expressive language. So any person who has learned English as a language other than their first language will attest to the fact that it's not a real easy language to learn. There's a lot that goes into the word and sentence structure that just has to be known, has to be memorized or understood. So it's not surprising that children with hearing loss need typically some attention brought to things like pronoun use, past tense, irregular past tense, or things like should have, could have, would have. So these are things that we also target in therapy. Most vocabulary is acquired incidentally by overhearing, and therefore becomes an issue for kids with hearing loss. We know that children with hearing loss don't acquire new words as easily as their peers without hearing loss, and that with a hearing loss, listening in noise is challenging. So acquiring new words becomes something that we want to target. In therapy, we consciously target vocabulary and coach parents in how to teach new words. This vocabulary success, so a strong vocabulary, is known to be a good prognostic indicator of school success. So the more we can do to enrich the vocabulary, the more we are doing to lay a foundation for academic success. Pre-speech therapy, pre-speech, the melody of the language, and speech, the clarity of the speech sounds, are an important part of achieving a natural sounding voice and intelligible speech. So historically, we've had struggles with this in children with hearing loss that have led to what's referred to as, quote, deaf speech. And these are the things that we work on in this area with a child and their parent, so that they're able to achieve a natural sounding and clear, intelligible voice. We also know that individuals with hearing loss, with severe hearing loss, have really struggled to reach a literacy level beyond the 4th grade. And this is certainly not for lack of effort on the part of teachers and interventionists everywhere. What we find is that there's a strong correlation between auditory development and listening and phonics that lead to reading. So basically, the children that have struggled in this area have learned to read, but haven't been able to make a transition from learning to read to reading to learn. And knowing this, we incorporate literacy into every therapy session and guide and coach parents in how they can help their child achieve, ultimately, an adult reading level. So what makes speech different than ABT therapy? We're often asked this. What's the difference? ABT at its core addresses the area of audition, which is not typically addressed in other types of speech and language therapy. As Abreu says, we're looking at growing the pathways in the brain so the child can rely on their hearing to learn to listen and talk. Maybe more tangible differences between auditory verbal therapy and speech therapy include things like auditory verbal therapy is typically once a week for 60 minutes. The parent is actively participating and really viewed as much of as the client as the child is. The focus in auditory verbal therapy is tying into normal development because now we have restored a sense that was limited previously. Auditory verbal therapy is also always individual. Speech therapy is outpatient or sometimes at school, is typically 2 times a week for 30 minutes. A parent may or may not be present in the session. The focus is generally remedial, assuming that something has deviated from the normal path and needs to be corrected. Speech therapy may be individual or it may be group. For example, in auditory verbal therapy, speech sounds are targeted through the perspective of audition. We move through a hierarchy of skills that begin by focusing on those things that are most acoustically different in how they sound, such as loud and soft volume, low and high pitch, to those speech sounds that are most alike, things like t and k, that even those with good hearing occasionally mishear. While we are working on this, we are developing what we refer to as the auditory feedback loop. An auditory feedback loop is how we all monitor our own speech to know if we're speaking too loud, we're speaking too soft, we're speaking too fast, we misspoke. And achieving a natural sounding voice and intelligible speech requires having a good auditory feedback loop. When people refer to deaf speech, they're noticing the results of an individual not having developed a strong auditory feedback loop. And if sound access is limited, it is extremely difficult to acquire. Speech therapy, in contrast, typically addresses articulation from a hierarchy standpoint of oral motor development in speech. Most children with articulation disorders have not had hearing loss. The sense has not been limited. So it's more likely that it is the development of the fine motor needed for speech that is a primary issue. So we have differences not only in how AVT differs from speech therapy, but within the realm of hearing loss, we have differences in how auditory verbal therapy differs from some of the other auditory oral options. Auditory verbal therapy is unisensory. We focus on making the hearing sense, the weaker sense in this case, strong. It involves parent participation, and we promote integration into general education early so that we are placing children with good spoken language role models. Auditory oral uses speech reading to supplement hearing, so you're using both hearing and vision. It's usually conducted in a classroom with a group of children who have hearing loss and can be really an important thing for some children who have received access to sound later or have other issues that are coming into play. The LSLS Auditory Verbal Educator provides sort of a hybrid approach. They do use a unisensory approach that is focused on the development of listening, but they often work in specialized classroom settings, so classroom for children with hearing loss. The long-term goal overall for all of these is integration into mainstream society using listening and spoken language. Breeze alluded to the principles of auditory verbal therapy earlier, and AVT is grounded in these 10 fundamental principles. They're considered the ingredients that go into a recipe for success. True auditory verbal therapy is only occurring if all 10 principles are met. I'm going to take you briefly through them. You have them here if you want to refer back to them. And know that anytime a child is not progressing as expected, an auditory verbal therapist is going to go back and consider what is happening in light of these principles. Principle 1 is early, and we've already heard this reiterated multiple times. Early diagnosis and early management. Principle 2 is technology. Being willing to go to the state-of-the-art technology needed to give that child good access to sound, even if that means surgery for a cochlear implant. Principle 3 is hearing. It's a unisensory approach. We are really focused on hearing and its use to develop listening and spoken language. Principle 4 is parents. This is an approach where parents are really coached to be the primary teachers for their child's listening and spoken language development, and that is what therapy is all about. Parents are also guided and coached in how to create environments that support listening that's needed to acquire good spoken language. This might mean turning off a television or implementing something like a one-voice rule at the dinner table. Principle 6 is listening. We want to help parents help their child integrate listening and spoken language into who they are and their day-to-day life. This is truly happening when you see a child that doesn't want to go to bed without their technology on their head. Principle 7 is typical development. We've talked about this earlier too, that we're really tying into natural developmental patterns and following the same hierarchy that happens in development of children with no hearing loss. Principle 8 goes back to the auditory feedback loop, and that the therapist is guiding and coaching the parent to help their child self-monitor their own speech through spoken language and listening. Principle 9 goes back to the idea of it's diagnostic, evaluating and monitoring progress all along the way so that the rate at which therapy progresses is the rate at which the child is able to progress, and so that if something is not going as we thought it should, that we recognize it and address it. Principle 10 is general education, promoting the participation in regular classroom settings with peers who have typical hearing and appropriate speech and language, so we're setting the bar high. And this really, for most families, becomes a way of life. The ultimate goal of auditory verbal therapy is to close the gap between the child's performance level in terms of their speech and language, and that it is expected of their peers with typical hearing at a given age. You can see in the graph that the blue line is age, the purple line is the cochlear implant age, and the green and red represent performance on language testing. So we start out with a fairly big gap designated by the arrows, and this gap narrows over time and hopefully closes. So we've got a lot of reoccurring themes in AVT: early, full-time device use, and parents. I want to also note that when all 10 principles can't be met in therapy, that doesn't mean that we can't use auditory verbal strategies and techniques to help get the best possible spoken language outcome. We refer to this as auditory-based therapy. And this is something that we often are using when a family comes in that maybe has immigrated from another country and a child did not receive access to sound early by our standards. And we're starting this development maybe at 4 years of age. They can still benefit greatly from auditory verbal intervention, but it's going to be called auditory-based because we're not going to expect that we're going to have a fast trajectory, and we may not close the gap, but we should obtain functional listening and spoken language for daily life. So AVT takes full-time device use. That's not easy. So it's important to keep calm and keep putting the technology on. When you're frustrated, I think it's helpful to remember that these aren't just hearing aids or cochlear implant processors. These are the tools that are giving your child's brain access to listening, access to sound, and they're the key to developing listening and spoken language. There's no question but what auditory verbal therapy is a front-end loaded process. The effort can be immense at the front end when you're putting the hearing aids back on and back on and back on, but the payoff is for the rest of the child's life. So we talk about things like using caps or headbands to help with retention. That said, we also hope to provide support to parents through the frustrating stage of keeping the devices on. Not only does it take wearing the devices, but unfortunately technology does break, or sometimes it gets lost. So we have to keep calm and the technology on. We also have to keep calm and keep the technology working. We certainly are a resource for loaner devices. If a processor is misplaced and you're not sure whether it's truly lost, or you might be able to find it. The Cochlear implant manufacturer, in the case of an implant, is the number you need to call to get parts and fix something that has, like a cable that has been broken. FedEx and UPS become your good friends. I had one child who called it the hearing truck. So let's look again at what AVT takes. Well, it does take time, not only for weekly therapy, but it takes time spent with your child. It's a great investment, however, because it's going to pay off for a lifetime. AVT takes trust. It takes trust in professionals. And it may start out with a family needing to trust that their child does need a surgery, and then placing their baby in the hands of a surgeon. No surgery is minor when it's your own child, and we recognize that. Ongoing therapy requires trust on the part of all parties. Trust that the therapist will understand when your child's having a bad day and flinging toys. Trust that the professional is giving you good guidance. And I encourage you to recognize the fact that at our center, we see children with a wide variety of outcomes across their lifetime, from infancy to adulthood and beyond. And we have recommended every communication mode we know of to one family or another. So it's about trusting that you're getting the guidance that you need to help your child achieve your goals. It does take therapy. We see over and over again that the children who consistently attend therapy progress more rapidly and end up with better outcomes. The child who comes once every 3 weeks does not progress at the same rate as the child who comes weekly. I love the picture at the bottom with the father involved, because another thing we see is that the more caregivers involved, the more carryover can be achieved in day-to-day life. Auditory verbal therapy also takes advocacy. A parent has to be willing to advocate for their child's needs for a good listening environment. We've touched on this again and again, but why is starting early important? It's because you hear with your brain, and early in life, the brain is flexible and adaptable. Why would a family choose auditory verbal therapy? Here's a parent perspective that I'm going to play for you.
How did you learn about listening and spoken language auditory verbal therapy? Obviously, when we landed here, they asked what our goals were for our son. And because we are a 100% hearing family, no history of hearing loss anywhere, on any side of the family, our goal was spoken language, 100%.
So there you've heard a parent perspective. Now, let's look at the child. This is Ellie at 2 stages in her therapy journey, which, as a Bree said, on average is a 2-year stint. For some it's a year, for some it's 3, but the average is 2. And you're looking for an outcome that gives you good listening and spoken language.
Hi, it's me, Ellie again. I received a cochlear implant in my left ear when I was 2 and in my right ear when I was 4. I like to use my cochlear implants because they allow me to hear sounds all around me, like my teachers and my friends talking, like music and movies, and like birds. I hate taking them off.
So in general, I believe that families choose an auditory verbal approach, or should certainly consider it, because it opens doors for educational, vocational, and social opportunities, and so that a child's path is dictated by their individual choices and not by the fact they have a hearing loss. We've got some resources here for you. One is AG Bell. Membership is free to families, and you automatically become a member both of the national organization and the state organization. Michigan AG Bell is actually having an event August 15th where they're meeting at a baseball game. Hearing First is a very reputable resource online that can provide you with a lot of information. The John Tracy Clinic has a wealth of documents and information online. The 0 to 3 website provides good information in general about early childhood development. And here's the 30 Million Words book that Abriz referenced earlier. We'll now take your questions, and we appreciate the time that you've taken to spend with us.